Thank you so much, everyone, for being here. And thank you all members and executive of the Nigerian Association of Medical Physicists. It's a privilege to be here. So let me share my screen and so that we can continue. All right, please, can you see my screen?
Yes.
Very good. So advances in radioimmunotherapy. And I have to use this occasion, this opportunity to acknowledge the very many excellent previous monthly webinars already organized by you. So thank you. We are talking today about radioimmunotherapy. You can see this injection being carried out. It is part of nuclear medicine, but there is also the radioimmunotherapy that is basically external radiation therapy plus immunotherapy. So this one is radioimmunotherapy in the sense of nuclear medicine, but there is another one, and we will talk about both of them today. And here is where I am speaking from, Creighton University. This is the city of Omaha, and Creighton University is just here. So I'm around here speaking to you, just to give some context here. And here is the outline of my presentation. I will be talking about cancers today and tomorrow in view of giving the reasons why we should advance radiation therapy and immunotherapy in combination. So from the introduction to challenges of current standards of care, basically the 3 pillars, but we now have 5 pillars. So we need to make sure that we expand to those. Then, since it is about radioimmunotherapy, it is important to introduce immunotherapy. That is number 3 there. And then radioimmunotherapy, the 2 types I mentioned earlier. Radiation therapy plus immunotherapy, and then targeted radioimmunotherapy, which is the nuclear medicine type of radioimmunotherapy. Then, since my research is largely focused on brain cancers, I will say a few things there. Then we will draw conclusions and take questions. So if you see here, there is a cell migrating. And just to make sure that everybody is back on track and I'm communicating, I have a question. So what is that cell doing and how is that relevant inside? So I like to interact with audience so that, yeah. So what is happening? Can anybody help me? Anybody who is watching the cell, what is the cell doing? And so that way I know that the session is interactive. Yeah, please unmute yourself and speak. Tell me what the cell is doing and how that may be relevant for cancer. Anybody, please? Yes, thank you, Bid Madhu.
I'm not too sure, but I think the cell is undergoing phagocytosis or so.
Okay, the cell is doing something that can lead to phagocytosis. The cell is actually migrating. So thank you so much, Madhu. Yes, the cell is migrating. So phagocytosis has to do with the cell moving and swallowing something. So it also entails the cell moving. So that was a very good guess. Thank you. And to take things further, How is cell migration relevant to cancer, since we as medical physicists and other professions involved in medical phys in cancer care are interested in treating cancer? So how is migration connected with cancer?
Hello, sir.
Yes, Dr. Samuel Adeneye, or yes,
Yes.
participant.
Thank you for the question. I would just like to say the migration aspect, that is what we refer to as metastasis.
Exactly. I can't add anything to that. Thank you. Both answers exactly. So the migration is what cells do. And when cancer cells migrate, it is a step in metastasis. And metastasis kills. Metastasis is responsible for over 90% of cancer-related deaths, more than you yourself know, oh, that it is bad news for the patient if you have any indication of metastasis. So my research is about not only killing the cancer cells, but stopping the process of migration that is an important step in metastasis. So that's why I am doing what I will be telling you I do towards the end of the talk. But this was to help me know that people are here and all that. I myself, I'm just waking up because it is 6 a.m. here. So back to the presentation. So can you see my slides? Have I lost people or something?
Yes, we can. We can.
Okay, so sometimes I may have to share again if it is not the appropriate display. All right, so Global Cancer Observatory. Many of you may have used this website, but it is very good in letting us have the numbers at a global level, but also to go in and see what is happening. It is data produced and presented by the International Agency for Research on Cancer, IARC. So there is cancer today, cancer over time, cancer tomorrow, causes of cancer, cancer survival, and all that. So we will look at cancer today and cancer tomorrow in order to see where radioimmunotherapy should come in or why it should come in. So starting with cancer today, here is the data for age standardized rate per 100,000. So this is for incidence and for mortality. So blue is for cancer incidence and red is for cancer mortality. As you can see on the graph on your left, starting with Oceania. Oceania is Australia and surrounding islands, New Zealand and all that. Then North America is largely United States and Canada. Then Europe, of course, then Latin American countries, that is LAC. That is Asia, and that is Africa. What do you think? You can see my question right there. What do you think about the mortality to incidence ratio based on this graph? Any participant, please? Any participant? Yes, please go on.
Yeah, to me, the mortality rate in Africa and Asia is about the same thing, but the rate of incidence is higher. in all other countries apart from Africa.
Excellent. Exactly. Thank you so much, that participant. I didn't look at who is speaking, but that is excellent. And so I took this data that you are seeing and plotted it. And I have the numbers to explain what that participant just said. Can you mention your name again, please?
Sam on the line.
Okay, so Sam just mentioned that the incidence may not be that high in Africa and Asia. But when you look at the mortality, then you see that the mortality to incidence ratio is high. So look at it. I plotted that data now here. And you now see that Africa tops in terms of mortality to incidence ratio. It means that if there are 10 people with cancer in Africa, what happens? How many will die? About 6 or 7. Do you agree with this table, please, participants?
Yes, we agree.
So that's the problem. And look at North America, the last one, which is Canada and United States. It means that if 10 people have cancer, only 2 or 3 may die. What do you think about that? The answer is obvious, that in Africa and Asia, we've got a long way to go in terms of managing cancer. And what are the reasons? Well, everyone here knows the reasons. I'm asking on the slide, why is Africa highest here? Lack of access to timely diagnosis, scarcity of treatment centers, and all that. And that is why I want to thank you, members of the Nigerian Association of Medical Physicists, very much, as I did during the interview that was published, interview conducted by Dr. Williams Igane. As I said there, I have a lot of respect for all of you working back in Nigeria, because it's like using your bare hands to save lives. You don't have enough treatment facilities, but you are there helping, doing what you can do. So thank you for working in such a very difficult environment and making efforts to even do better despite the challenges. So radioimmunotherapy is here. I'm speaking about radioimmunotherapy as a way of presenting new treatment modalities that can help us lower this ratio. So many treatment modalities are not available or adequate. Radiotherapy is very inadequate in Nigeria. The machines are too few. And immunotherapy is just beginning, if at all. And so we have a lot to do. So taking the pulse at cancer today in Nigeria, look at this. We have only 14 radiotherapy centers in the country. 9 of them belong to the government. Only 5 of them belong to private, and only 6 of them are licensed by the Nigerian Nuclear Regulatory Authority, which means the others are not safe. In terms of equipment, Nigeria has only 7 LINACs for a population of 200 million people. South Africa has 92, and Egypt has 76. In those days, when I was in Nigeria, we used to have questions in class. Who made that statement? To whom was that statement made? So who can guess who made this statement? Think about it, but let me give the answer so that we don't delay. It was Dr. Yao Idris, Director General of the Nigerian Nuclear Regulatory Authority. And he made the statement on World Cancer Day Symposium in Abuja only 2 months ago, or 3 months ago, February 5th, 2024. Can you see? That is taking the pulse of the inadequacy of treatment centers, treatment facilities, and all that. We've got to do better. And so let's look at what is happening in the United States, cancer statistics in the United States. So the situation this year. Look at prostate cancer. Look at breast cancer. Look at the percentage. That is in terms of new cases. So I show new cases, estimated new cases. And then you can compare it with estimated deaths. It confirms what we saw previously, that they have managed to reduce the incidence, the incidence to mortality ratio drastically. And so, since I will say a few things about brain cancer, You see that brain cancer and other nervous system cancers, only 3%, even though the incidence is not increasing, but the mortality, the death is still relatively high. All right, so how about cancer tomorrow? And what is tomorrow? We have estimated data for 2022 to 2045. So over 20 years from now, where will things stand? According to the IARC, so IARC is the international one. Look again, Asia, see red tomorrow. Look at Europe, look at North America, look at Africa. Again, if you take a close look, it will seem that the incidence, the increase is not that terrible. But if you take a ratio, you now know that we are in big trouble. And that is exactly what I did with the data, the graph on the right, the one that my pointer is on. So let's take a good look at this graph, cancers tomorrow. In this graph, the percentage increase is plotted. HDI means Human Development Index. So where does Nigeria belong? Anybody just tell me the color. Where does Nigeria belong in terms of color there? Is it green or red?
Red.
Exactly. So Nigeria is in the low HDI countries. And look at the percentage increase that is estimated between 2020 and 2040. We are in the top list. So there will be a lot more cancers. You will be increasingly needed around the world, especially in our locality back home in Nigeria, because cancer incidence is going to be high back there. And yet we are not ready in terms of equipment, in terms of treatment modalities. That's where we're talking about this new treatment modality. So low Human Development Index countries have highest percentage increase. That's a huge problem, stretching resources that are not even there in the first place. So estimated number of deaths. So previously, the previous slide was on incidence, and now the number of deaths, the estimated mortality. You can see that Africa is again going to be very high compared to the incidence. Incidence is blue, and then red is mortality. So are these estimates inevitable? That's my question. Estimates are based on current trends. So you and I can do a lot to change the current trend. And radioimmunotherapy is one of those modalities that we can introduce to change the current trend. So that leads me to standards of care. The traditional ones are surgery, radiotherapy, chemotherapy. And now we have a few new ones, but let's talk about these major standards of care or pillars of treatment. The summary on this slide is that these pillars of treatment will continue to be important. That's why I have it here. More than 50% of cancer patients require radiotherapy and will continue to require it. So the new treatment modalities do not threaten the well-established ones. The well-established ones have not succeeded in curing cancers or in managing all cancer cases. So we are in need of new treatment modalities in order to reduce the mortality rate of cancer, in order to get closer to a cure. So surgery, radiotherapy, chemotherapy, these will continue to be in need. So pillars of the traditional three pillars now have two extra ones. What are they? The two new ones are molecularly targeted therapy and immunotherapy. So those are the two new ones. And you can see 1990s to present, 1990s to present, two new pillars. let's go into some details about these new pillars. Details I will emphasize. So the new pillars in some cases lead to new combinations. For example, surgery, chemotherapy, radiation therapy, and immunotherapy. So when you combine radiation therapy with immunotherapy, you end up with one example of combination therapy. So radioimmunotherapy is one form of combination therapy. And in this presentation, when speaking about immunotherapy, I'll be focused on one aspect of it, the immune checkpoint blockade type of immunotherapy. When speaking about improving radiation therapy, I will be focusing on radiosensitization. There are other aspects, there are other ways of improving all the 5 pillars of cancer, such as cancer nanomedicine, just showing that things like that are going on, but my focus is on radiotherapy and immunotherapy. Now, talking about immunotherapy, since we are going to combine immunotherapy with radiotherapy, let's make sure we get deep into immunotherapy itself, which is a relatively new pillar, although the actual discovery was done a long time ago. It may interest you to know that back in 1891, it was discovered by Dr. Coley, and he discovered it almost like in a surprising way. He didn't really realize that that might lead to something so important. He observed by reviewing the literature that patients who had infections somehow managed to not have the outcomes, the same outcomes as more healthy patients. So the patients who had concomitant infections due to other ailments, ended up better in some cases. So such patients were largely from underserved backgrounds in lower Manhattan in the United States. Infections include sexually transmitted diseases such as syphilis. So there's an example of a German immigrant named Stein, whom Coley searched for and found in Manhattan, and the person had no evidence of cancer after the treatment. So Dr. Coley correctly deduced that this patient and patients like him were having their immune system take over to handle cancer. And that is where the science, the basis was laid. And in 2018, the Nobel Prize in Physiology and Medicine was jointly given to James Allison and Tasuku Honjo for their discovery of immunotherapy, precisely the inhibition of negative immune regulation. And to be even more precise, they discovered immune checkpoint blockers that can now be made into drugs that actually block those immune checkpoints or unblock them, as the case may be, in order to help the immune system fight cancer and overcome the way cancer cells shut down the immune system. So that is immunotherapy discovery. And now we move on to advances in immunotherapy. There are so many different types of ways of getting the immune system itself to fight cancer. And the ones that I'm going to work on or speak largely about will be checkpoint inhibitors. But these other methods are also under big development, and we can have several webinars around it. So focusing on checkpoint inhibitors, how does this work? Basically, I give an example. Without immunotherapy, on this graph, without immunotherapy, you can see that here is a tumor cell. And here is the T cell that should recognize the tumor cell and fight it. But there is a binding, there is something here, a connection between surface proteins presented by the tumor cell and the T cell that makes the T cell assume that this tumor cell is part of the body. Are we together? Now, this is one big mechanism by which cancer cells, tumor cells, evade the immune system and therefore thrive and kill the patient. The blockade, yes, this checkpoint is allowed. It is the way normal cells enable immune cells to recognize that, okay, this is part of the body. So this tumor cell is pretending to be part of the body thanks to this connection between the programmed cell death ligand protein and the programmed cell death protein. Both of them one. That's why they bind. So what immunotherapy does in the case of checkpoint inhibitors is to send molecules, anti-PD-L1, that can bind to tumor cells, or anti-PD-1 that can bind to T cells, to block this blockade or to unblock this blockade, if you like, so that the T cell, the immune cells, are now free to do their part and see this immune or this tumor cell as an enemy and therefore fight it. That's one example of immunotherapy. Very powerful, very systemic, and it should work. But unfortunately, it does not work for all cancers, and it is more complicated than that. To show the complication, decades of research led to immune checkpoint blockers. From 1974 there, a lot happened. And I will have these slides available in case you're interested in the history up to July 2023. Let's pinpoint two big moments in the history of the development of immune checkpoint blockers, 2018 and 2023. So 2018 was the Nobel Prize there. And then last year, even more checkpoint inhibitors were approved by the Food and Drug Administration of the United States. In other words, we now have a lot more immunotherapeutic drugs that do what I just explained. So newly FDA approved anti-cancer agents, there are very many, and they are newly approved, meaning that we have a new dawn of cancer therapies, of immunotherapy. Take a look. Surgery, chemotherapy, and radiotherapy, very few new agents. And those new agents are largely in terms of imaging, not therapy. But look at, so this is our advances, we are on advances in immunotherapy. But look at molecularly targeted therapy, several new agents approved by the FDA. And then we quickly go on to immunotherapy, which is our focus. So look at immunotherapy. You can see lots of them, durvalumab, atezolizumab, and so many, acting against various forms of cancer, liver cancer, skin cancer, gallbladder, lymphoma, etc. So there's a lot of new immunotherapeutic drugs available now, approved, and people are going to start to use it. And I'm saying, hey, in Nigeria, we need to join. It's a new pillar, and there are many new agents. Okay. And in order to join, let's look at some of the cancers that have been treated, in many cases successfully, relatively, I mean, in terms of 5-year survival, using these agents. And so you can just take a look. I don't expect you to be able to read it, but in terms of combining radiation therapy and immunotherapy. So we are looking at those various cancers, cancer sites where immunotherapy has really helped already. Head and neck, lung, liver, bladder, cervical, endometrial, colorectal, kidney, all they have very well established or newly established immunotherapeutic agents. For example, breast cancer, pembrolizumab works. Esophageal cancer, nivolumab works, and all that. So that is what this table is. And the challenge now for us medical physicists is how to take these newly approved agents, see, 2023 approval, and combine them with radiotherapy to come up with radioimmunotherapy that should lead to better treatment outcomes. That is the idea. And to repeat that idea in a graphical way, I have this slide. So think of our patient right there on the slide and think of this graph. On this graph, no treatment. You see the survival is very low over time. But with radiation therapy, what you are currently doing as medical physicists, see the survival. With immunotherapy alone, see the survival. The idea, the hope, the strategy, the goal is that combining immunotherapy with radiation therapy should lead to this outcome. But there are many challenges. So let's give an example of such a combination that worked very well recently. Clinical trials. You could see lots of them. There are lots of clinical trials that were done, and some of them have worked. And I give this example of this Spiegel study called the Pacific study. It was a phase 3 clinical trial involving non-small cell lung cancer. And the participants, the people who handled the study, and even the patients came from so many different centers in many countries. And the median overall survival showed significant improvement when the patients were treated both with durvalumab, which is immunotherapy, immunotherapeutic agent. I mentioned it in previous slides. So the patients were treated with both durvalumab, an immunotherapeutic agent, an immune checkpoint blocker, as well as radiation. And the radiation was given in 60 to 66 grays in 30 to 33 fractions to the primary tumor and involved nodes in the tumor. So what was the improvement? Look, 45.5 months median overall survival for patients who were treated with both durvalumab and radiation therapy, compared to 29.1 months of patients who had only radiotherapy without durvalumab. Can you see? So a very important, a very significant improvement in treatment outcome. That's the idea. But as I said, there are challenges. So favorable clinical outcomes demonstrated with the sequential radiotherapy and immunotherapy using ICI agents. Challenges in identifying the optimal regimen for the immunotherapy is a big one. And there are also challenges regarding how much dose and dose fractions should be given when combining radiation therapy with immunotherapy. And then people are also currently looking at potential biomarkers to show which patients are likely to benefit from the combination of radiotherapy and immunotherapy. So that's where things are. And my research addresses some of these challenges. And there are thousands of other researchers, clinical researchers, working to address these challenges. So these are the advances in radioimmunotherapy. This is where things are addressing the challenges to make it work better. So in my lab, I'm trying to get biomarkers that will show which treatment is working well and things like that. A lot of tools to do that. One of which is measuring cell migration, which is something I emphasized at the beginning. If you notice, cells are migrating. Can you see cells migrating? And the graph, the data is real-time data. As the cells cover the electrode, the rate of migration is measured electrically in terms of the resistance. The resistance on the electrode is increasing. So I have these gold-plated electrodes in my lab. I let the cancer cells migrate and then measure the resistance as a form of measurement of the migration. And then when the cells are treated with those cancer drugs, as well as with the radiation therapy, we see the therapeutic effect in terms of whether it reduces the migration or not. And most of these results have been published recently in my lab. As you can see, development of in vitro assays for advancing radioimmunotherapy against brain tumors. So that's publication from my lab. And the rest are also from my lab. And the way I address these challenges is what makes you and I physicists. We use physics to get more information from the ordinary biological data. So this is an example of the physics that we do to extract more information. So as the cells migrate on the electrode, as you saw in the video previously, that migration can be measured in terms of the resistance. And after we get the complex resistance, we can write this formula, we can model it and extract such parameters as the barrier function that tells us to what extent the cells, cell-to-cell connections happen. So to what is the strength of cell-to-cell connections so that we can measure local tumor invasion. If a drug is actually reducing the barrier function, for example, it means that that drug might work to reduce local tumor invasion, might work to reduce metastasis. That's the idea. So this is the kind of modeling going on in my lab. It's kind of tedious, but we're doing it and we're happy with it. So in terms of other pieces of research going on in my lab, there is radiotherapy, cell mechanics, chemotherapy, cancer metastasis, and even physics of sickle cell. So I will not go into the detail, but this slide is just to give a broad perspective of the kind of work I do in addition to radioimmunotherapy. So you can see nanoparticle-mediated radiotherapy plus radioimmunotherapy against cancers. So I'm coming now to the last part of radioimmunotherapy. We've just done the one that I think that many medical physicists can actually handle. You already work with linear accelerators. And now if you are in a team of physicians, a team with oncologists who are interested in immunotherapy, then you can begin to combine these approved immunotherapeutic agents with your radiotherapy regimens and then study outcome and see if it helps patients. And you don't have to start from scratch. It's already established in some cancers, non-small cell lung cancer, for example. That's a good place to start from since we know the drug, the immunotherapy that works and all that. And now the second part of radioimmunotherapy, which is radionuclides plus peptides or antibodies. I was very, very impressed when I looked through some of the previous webinars, one of which was about nuclear medicine and dosimetry by, I think, Dr. AJ, and he did a fantastic work. So the details of nuclear medicine are there in your previous webinar, and I suggest you contact it. But here, briefly, radioimmunotherapy involving radionuclides means you take a radioactive particle, maybe iodine-131, combine it with an antibody and inject it into the patient, such that the antibody will then home at the exact cancer location, while the radioactive particle, the radionuclide, stays there, giving local radiation through radioactive disintegration. Could be beta particle, could be alpha particle. So this is well established. It's not completely new, but it is growing with precision in the way of actually getting the molecule into the body. So there is pre-targeted radioimmunodiagnosis and pre-targeted radioimmunotherapy. And here, there is the combination of antibodies and radioisotopes, high contrast imaging, and at the same time, high therapeutic index. It means you put a kind of radioactive particle that gets in there as it is disintegrating and depositing dose. It is also sending out gamma rays that you can use in imaging. So it is very good. You are doing both therapy and even imaging to keep track. It's a bit more complicated, works, has its challenges, but it is there and it is being improved. Currently, there are 2 RIT agents approved by FDA, Zevalin and Bexar. And to tell you that there are still problems, let me indicate that one of them has been discontinued because more problems were found than when the clinical trials were carried out. So Bexar has been discontinued, but Zevalin is still there. And Zevalin uses yttrium and ibritumumab to create this radiopharmaceutical for radioimmunotherapy. So in radioimmunotherapy, when it is targeted, you get things like this. You could advance it using PET imaging. So PET imaging shows the time progression of the radiopharmaceutical after it has been injected into the body. In this case, it has been injected through the spinal cord, and it has been made to target the locations of the tumor right there. See, 2 hours after injection, 24 hours after, and then 48 hours after. You can see those locations and watch in real time, both as prognosis and as therapy. The therapy is going on and you are seeing what is going on at the same time. So advances in targeted radioimmunotherapy. So this paper shows so many clinical trials that have been done in the past 10 years for different kinds of cancers. So solid and non-solid tumors, all of them past 10 years. And then clinical trials for non-solid cancers, so leukemias and all that, blood cancers in general, and then solid cancers alone. So you can see that there are some cancers where radioimmunotherapy, targeted type, has been done extensively. That's the type that you want to then think of adopting in your center, since there is more clinical evidence or more research done in terms of you are adopting it. So that's what this graph is for. And now, finally, I'm coming close to the conclusion. Radioimmunotherapy against brain cancers, which is my main area of specialization. That paper, preprint, is from my graduate student or based on the work by my graduate student. So in the United States, there are over 1.3 million people living with brain tumors, and glioblastoma is the worst of them. It's the worst, it's the cancer with the worst treatment outcome. Some oncologists, my collaborators, say that it is a death sentence. The average survival is 15 months if all three modalities of treatment are done, namely surgery, and then radiotherapy and chemotherapy using the only FDA-approved drug against brain cancer, which is temozolomide. But it doesn't work for 50% of patients, unfortunately. And even when it works, the survival goes to only 15 months. So supposing you are not treated with those three modalities, surgery, radiotherapy, and chemotherapy using temozolomide. Supposing your brain tumor, your glioblastoma is left untreated, how long do you live after diagnosis? Just 8 months. And it has been so for the last 30 years. So work in my lab is focused on changing this using radioimmunotherapy, and it is very challenging. So I'm also adding nanoparticle mediated radiotherapy to radiosensitize the cells before or in addition to the radioimmunotherapy. It is tough work. Let's leave it there. So, and it's not just done by myself. And then how can we collaborate with some members of the Nigerian Association of Medical Physicists? So fortunately, thanks be to God, I've used my resources and those of friends and others to build 2 research hospitals in South Nigeria. And I call them Joseph Ukpo Hospitals and Research Institutes. The plan is to have 3, but 2 sites are functioning right now. And we have over 70 volunteer clinicians, and we do both. We give 100% free healthcare. You don't pay even for card. Some participants here are from the hospital, in case you want to find out. The website is right there. And we do cutting-edge research. So if you're interested, we can collaborate. We're trying to build a cancer center. And this is we have, fortunately, a 640 slide CT scanner donated by the lady you see here, Dr. Tayo Denton. And we are naming it, she donated it in honor of her mom. And we are setting it up in our second facility that is shown here In fact, it is the CT scanner that is right there inside that container. And by the grace of God, we want to take it out of that container into our new cancer center under construction, as you can see in that picture. So I hope that we will be able to collaborate when we set up this cancer center using one of the most advanced CT scanners available. And our hope, we already have plans to collaborate with MD Anderson Cancer Center here in the United States, because they are training AI to do AI-assisted diagnostics. And they need images from around the world. They need diagnostic images from CT, PET, MRI from around the world, not just patients in the United States. So our collaboration will produce those images from cancer patients in very, very remote areas to add to the training of the AI, to make the AI even more robust in terms of diagnostics. So that's the collaboration already in the works once we put up this cancer center. And it will be nice to collaborate with people from the Nigerian Association of Medical Physics. So finally, the conclusions. Immunotherapy is now a fourth pillar of cancer care. Targeted therapy is now a fifth pillar of cancer care. And combinations of radiotherapy with immunotherapy, which is radioimmunotherapy, one arm of it is rising. Another arm of radioimmunotherapy, targeted immunotherapy, radioimmunotherapy is also growing. So you have lots of options to change, to advance your care modality, to enhance your professional relevance and end up reducing that statistic that was not so favorable to us, the incidence to mortality, the mortality to incidence ratio, which we started from. And not only you, but people in other parts of the world, whether advanced or advancing, all are interested in patient-specific treatment and prognosis. And radioimmunotherapy is one of those combined modalities that ensures you can look at the patient, look at what they're going to, they may likely respond to, and get and tailor their treatment according to their physiology. Let's put it that way. So patient-specific treatment opportunity is very strong in terms of radioimmunotherapy. So that's where I end, and I thank my entire research group. That's my contact information. If you scan on the QR, it will take you to my WhatsApp, and it makes communication easier. And I thank my research collaborators from around the world. These are my research students. Thank you for listening. I think I've taken 40 minutes. I was supposed to, and I can take questions.